Hello, today I would like to talk about the ECG basics and the knowledge that is required for the physiology exam, and I hope that in the end you will have a good understanding about how to analyze an ECG and how to recognize some basic arrhythmias. First, I would like to talk about the channels that are present in the cardiomyocytes. There are the sodium channels, which are for rapid depolarization in the atrial and ventricular muscle and in the Purkinje fibers. These channels are not present in the nodal cells, the SA node and the AV node. Then there are the calcium channels, which are also for rapid depolarization, and they are present in every cell in the heart, every working cell and conducting cell in the heart. Then there are the potassium channels, which are for repolarization of action potential. Also, again, they are present in every cell. And then there are the pacemaker channels, which are abbreviated IF for funny channels. They are present in the nodal cells, and why they are so funny, I will talk about it in the next few slides. Okay, now we have to talk about the action potentials which are generated in the myocardium. There's the phase 0, which is connected to the depolarization of the cells. In the ventricular muscle, it's connected to the inward current of sodium and calcium channels. And in the nodal cells, there's only the calcium channel, like I said before. Due to that, there's a higher amplitude in the ventricular muscles compared to the nodal cells. Then phase 1, which is not present in the SA node and the AV node, leads to rapid and very short repolarization of the action potential. This is due to complete inactivation of the sodium and calcium channels and a minor activation of a repolarization current called ETO, it stands for transient outward current. So a very small, some potassium channels open and there's a repolarization for a short time. This activates then some calcium and sodium channels again, which leads to the plateau phase. Again, this is not present in the SA node and AV node. This is only present in the muscle cells of the heart. Then there's phase 3. This is fortunately present in both cells again, or types of cells. This is due to the opening of potassium channels, which causes repolarization of the cell. Then there's phase 4, where every channel in the ventricular muscle is inactivated and the action potential is 0. In the AV node and SA node, it's a little bit different because there are some hyperpolarization activated channels. Like I said before, these are the funny channels. I will talk about it in the next slide in more detail. They lead due to hyperpolarization. They get activated due to hyperpolarization and produce an inward sodium current, which increases again it's written here, which increases again the action potential until the threshold is reached and another action potential is generated. Like I said before, this is the pacemaker current. I already explained it. These are activated via hyperpolarization. It's very important. And there are no cells in the body which exhibit this specific feature. So they are very special, and that's why they are called funny, because they act totally different than every other cell. Now we need to talk about the AV delay. When the SA node will send action potentials, the atrioventricular node needs to decrease the conduction speed. So like I said before, in the nodal cells there are no inward sodium channels compared to the ventricular muscle and the atrial muscle cells. Then in the AV node there are less nexus, which also leads to a decrease in conductance of the action potentials. And the cells are oriented horizontal in the direction of conduction, so it takes longer time for them to go through the cells. This is very important because the teachers really want to know you to understand it if you get this question. You understand the channels and the basic action potentials of the cells. We can start with ECG. So first of all, what's important is that you understand the difference between a lead and an electrode. As I already have written here, a lead records the vector voltage difference between positive and negative electrodes. So that means when there's an action potential or a depolarization vector going from negative to positive, we have an upward deflection. And when it goes from positive away towards the negative, we have a negative deflection. And if it goes perpendicular to the lead, from negative to positive, then the line on the ECG is isoelectric. So we have bipolar leads and unipolar leads. Bipolar leads, like it already says, are bipolar, so they are negative and positive. Negative and positive, negative, positive. These leads are only 1, 2, and 3. The rest are unipolar leads. Unipolar means that there's a positive electrode, but also a neutral electrode, which is calculated approximately in the middle of all the electrodes. Here's illustrated how you put the electrodes on the body. And again here for V1 to V6, also for the chest leads, how you put them, but I suppose you already know how to do it. ECG waves. What is important, I used lead 2 to explain how the ECG waves are created. Again, this is the negative electrode and this is the positive electrode. So we know that every vector going towards the positive electrode is also a positive upstroke. So first of all, the P wave. This is the depolarization of the atria. And the general vector is from the SA node downwards and to the left. This is recognized by the P wave. So the P wave is a depolarization of the atria. Then we have the depolarization of the ventricles, which is the Q, the R, and the S wave. The Q wave is the septum depolarization from left to right, which is normally a little bit negative if we use lead 2. Then we have the R wave going up because it goes in the direction of lead 2 or in the direction of the positive electrode. And then we also have the S wave, which is a little bit negative because it goes away from the positive electrode. And the general depolarization goes towards the left ventricle and not to the right, because the left ventricle is larger and has more action potentials than the right one. And what is very important, the repolarization of the ventricle is explained by this sentence, that the last cell that depolarizes is the first cell to repolarize. This is very important because otherwise you wouldn't understand how the waves are created, because during the contraction of the heart, the channels are compressed and they cannot open and let the potassium current in. So now you maybe think, okay, the last cell that depolarizes is the first cell to repolarize, so normally the vector should go like this, in the opposite direction, so it should be negative. Generally, it's a good idea, but you have to remember that the repolarization is negative and the depolarization is positive. So when there's a negative repolarization in this direction, so negative to negative, that gives positive. So we have the T wave, which is positive. Okay, now I talked about PQRST, and you probably have never heard of it. So I will talk about it now. This is a sinus rhythm. The sinus rhythm is defined by the heart rate of 60 to 100 beats per minute, and there's one P wave before every QRS without PQ prolongation, and the rhythm has to be regular. You can count the squares and or use the paper and mark 2 QRS complexes and move along with every QRS complex and see if it's regular. You can do it when you're in the clinic. Now the PQ time has to be below 200 milliseconds. The QRS has to be below 100 milliseconds. And now to understand how to describe some rhythms, because in some pathologies it's important to know and to understand this. The Q wave is the initial negative wave, the R wave is every positive wave, and the S wave is every negative after the first positive wave. As you can see maybe in this ECG as well, not every lead there's always the QRS, but maybe just some of them, which is not a problem, but you just have to know that when you describe an ECG, that, for example, in this case, there's no initial Q, so this is only R and S. That's no problem, but just to understand it, for some pathologies you have to know it. But for now, it's not that important. The QT time from Q to T is around 350 to 440 milliseconds. Now I will explain how the different leads look like on the ECG and why. So in general, you have to you know from the previous example, before the depolarization, of course, there's the isoelectric line because there are no action potentials. Then the depolarization of the atrium, the P wave, is positive because it goes to the positive electrode in lead 2. Then, due to the AV delay, we have again the isoelectric line because there are no action potentials at that moment. Now, the septum depolarizes from left to right, so we have a small negative, which is the Q wave. Then, the general vector goes up towards the positive electrode, and some vectors also go to the opposite direction, so we have the basic QRS complex. The repolarization of the ventricle, like I said, goes to the opposite direction, but it's negative, so negative and negative goes to positive. So now we have lead 3. Lead 3 goes from left to right, so it goes like this. So the first wave again, there's the isoelectric line. Then in this case, the depolarization goes a little bit to the opposite direction, just a little bit. So maybe we can say it goes down just a little bit. Then the isoelectric line because of the AV delay. Then there's the septum depolarization, which is in this case positive because it goes to the positive electrode of lead 3. So we have the positive upstroke. And again, the general vector to this direction, which is not completely perpendicular, but a little bit positive. So we have a positive upstroke and some negative going towards the right. So we have a negative as well. Then the repolarization, again to this direction, might be also a little bit positive. So we say here's a little positive wave. This is how it looks for lead 3. But for this, it's just important that you understand how I write this. Of course, in real life, it's very different. But if you understand this, then you will understand why the leads look like this on the ECG paper. Now, AVR. AVR, it's the opposite direction of lead 2. So it goes to this direction. I will write lead 3 and AVR. So basically it's just the mirrored lead 2. So again, isoelectric line, we have the atrium depolarization, which is negative, of course. Then AV delay, we have the septum depolarization, the ventricle depolarization, and the repolarization. Okay, now we can talk about the heart axis. What is the heart axis? It's the main depolarization vector of the heart. This is important because in some cases we have, for example, left ventricular hypertrophy. There's even steeper depolarization in this direction towards the left. Or for example, if someone is very obese or if a woman is pregnant, the heart gets pressed a little bit to the left. So the main vector also goes more towards 0 degrees. We can use the Cabrera cycle to find out the axis of the heart. And there we have to look at all the leads. 1, 2, 3, AVR, AVL, AVF. And here we have to find the lead with the highest amplitude, which in this case it's lead 2. So we already know where the main vector goes, or the main axis of the heart goes. But in lead 2, which is 60 degrees, it's just between the normal axis and the vertical axis. In this case, we have to know if it's either normal or vertical. How do we do it? We have to look at the perpendicular lead, which in this case, it's AVL. If it's more negative, then it would be a vertical axis. But it's a little bit more positive, so we can say it's the normal axis of the heart. The axis of the heart, like I already mentioned, depends on many things. It's also depending on the physiological anatomy of every person. So it's between 0 and 120 degrees, it can be normal. Of course, if there are some troubles or if the axis changes over time, we always have to think about some pathologies. Here's a more simplified version how to estimate the heart axis What is important here is that you have to look at lead 1, lead 2, and lead 3. And you have to look at the QRS complexes. So for example, if in lead 1 the QRS complex looks like this, then you see approximately there's more positive deviation than the negative. So you can put a positive and a plus sign. And if the lead, for example, in 2 looks like this, then you know the QRS complex is mostly negative, so you can put a negative and so on for the third complex, for the third lead, the same. What you have to think about here is, as you can see, for the normal axis and the vertical axis, all the QRS complexes are positive. So you can differentiate this and looking at the first and the third lead. And if the first lead has a greater positive amplitude than the third, this leads this is how you know that's the normal axis. And if the third if the amplitude on the third lead is larger, then it's the vertical axis. Also, what's important, that the lead 2, the QRS complex, is only negative when the axis of the heart is larger than 150 degrees. So as you can see here, the right axis deviation starts at degrees higher than 120. So, and you can only see the completely negative QRS when the heart axis is above 150. So this table is not that good in differentiation to find out the right axis deviation. So we can talk about arrhythmias now. Before we analyze an ECG, we have to see if there are QRS complexes or not. If not, we have an asystole, which means that there are no action potentials in the heart. Then, if there are QRS complexes, which is mostly the case, we have to look at the rhythm, if it's regular or not. That means we have to look at the R waves and compare them to each other if they're in regular distances. Then we can look at the frequency. If it's between 60 and 100 beats per minute, we have the normal sinus rhythm, if there's a P wave and the QRS is small, and the time between P and QRS is below 200 milliseconds. Then we can look at the waves, which is not that important yet, but for example, if the QRS wave or QRS complex is larger than 100 milliseconds, it means that there's a pathology. And we can look at the heart axis, which we just talked about in the last slides. Now some terms for the arrhythmias. If the heart frequency is below 60 beats per minute, we can call it bradycardia. If the heart frequency is above 100 beats per minute, we call it tachycardia. In general, the arrhythmias are differentiated into pacemaker activity disorders, re-entry, triggered activity, but it's not that important yet, only for pathology and pathophysiology, so I won't talk about it in this lecture. And we have conduct blocks. The conduct blocks which are important for physiology are the AV blocks. The AV block is differentiated in different degrees. We have AV block first degree, which is just the prolongation of the PQ time above 200 milliseconds. So that means we have a P wave in front of every QRS, but the time between P and QRS is just prolonged. Then we have AV block second degree, which is differentiated in Wenkebach and Mobitz. In Wenkebach, we have the prolongation of the PQ time with every contraction until one QRS is missing. And then, because the SA node is intact, it still fires regularly. So after the one QRS is missing, again there's a P wave, and the rhythm starts from the beginning, and the PQ time again prolongs, and then there's a QRS complex missing. In AV block second degree Mobitz, we have the constant PQ time, and there's just some of the action potentials are just not going through the AV node, so there's a missing QRS complex. But again, the SA node still fires regularly, so the rhythm still goes on, but sometimes there's a QRS complex missing. And then we can differentiate between 2-to-1 and 3-to-1 and 4-to-1 and so on. So that means there's a P wave, a QRS, there's a P wave, and then no QRS. And then again P wave, QRS, P wave, no QRS. That means we have a 2-to-1 AV block. In 3-to-1, we have a P wave, a QRS, again a P wave and a QRS, and then a P wave and no QRS. So this is 3-to-1. In AV block 3, we have the complete dissociation of P and QRS. That means the atrium and the ventricle are contracting completely independent of each other. This is due to the fact that the AV node doesn't conduct any action potentials coming from the atrium. So we have the P waves, which are regular. We see these on the ECG. And the QRS complex, which is also there, but the AV block is not conducting and not doing anything. So the next pacemaker cells are the Purkinje fibers. The Purkinje fibers, unfortunately, only make a rhythm from 20 to 30 beats per minute. So it's very slow. The patient is mostly very unstable and has a severe bradycardia. And AV block third degree is always an emergency. So now some examples. The normal heartbeat or sinus rhythm, like I already said, it's the PQ time below 200 milliseconds, the QRS time below 100 milliseconds, and there's a regular heartbeat. Then there's the tachycardia, which is the beats per minute are above 100 beats per minute, and the bradycardia, where the heart rate is below 60 beats per minute. But there are no changes. The PQ time is normal short, the QRS time is short, and the rhythms, the contractions are regular. Then, as we have talked about the AV blocks, here are the ECGs. So we can see in the first degree AV block, there's a prolongation of the PQ time, but the rhythm is still regular, just the prolongation between P and Q. Then we have the second degree AV block Wenkebach. Here's the prolongation, or here's the normal PQ time. Then there's the prolongation of the PQ time, an even larger prolongation. And then there's a P wave, but no QRS following. But after a certain time, the AV node, the SA node fires regularly. So again, there's a normal P wave following QRS. And then afterwards, still, again, it goes It prolongs until there's no QRS, and it starts from the beginning. The second degree AV block Mobitz. Here we have the PQ time normal. Sometimes it's prolonged, sometimes it's not. But after some contractions, there's no QRS complex. But again, the SA node fires regularly, so there will be following again a P wave with a QRS. And here we can see the second degree AV block 2 to 1. There's a P wave, a QRS, a P wave, and nothing. And then again, P wave, QRS, P wave, and nothing. P wave, QRS, P, and nothing. This is 2 to 1. And here we have the third degree AV block. We can see this is a P wave, 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 and this is a P wave. But they're totally dissociated from the QRS complexes. And here there's an example. Maybe you can pause the video and think about it for yourself. But I will explain. So, okay. What do we see? We have to look at every lead, at every complex. There are complexes, so we know it's not an asystole and the patient is, or the heart is beating. What is good about this ECG that we have some long stripes, ECG stripes, and we can look at this more in detail. Here we see a P wave, we see a QRS complex. Again, QRS complex, QRS, QRS, QRS. And in between, there are some P wave or maybe some T waves. We have to look even more in detail. So there's a P wave, then there's a QRS, very late. And this is also a P wave because this is the T wave. Then there's again a P, a fused P with the T wave, again P wave, P wave, P wave, P wave, P wave, again fused, P wave. So we know the P waves are regular, but they are completely dissociated from the QRS complex. So it should be third degree AV block. Re-entry is a little bit more difficult, but I try to explain it to you as easy as I can. For re-entry, we need 3 requirements. First of all, what's important? We need to have a closed conduction loop. That means we have action potentials going on one side and on the other side and meet again. For the re-entry to happen, the myocardium needs to be damaged at some point. So that means we have an ischemia, so a decreased blood flow to one area, and the cells are dying. So on one side, the action potential goes normally very fast, and on the side of the ischemia, the action potentials go more slow and still meet at the end and go down. So that means if the ischemia is getting worse, we have a region of unidirectional block. That means the action potential again on this side is going fast and on this side is not going further than the ischemia. But if the conduction on this side is going fast, and these cells are again ready to depolarize, and the action potential from above cannot pass by this ischemia. The action potential goes again up this loop, and because it's a unidirectional block, it can go and pass by this ischemia region and then again has its own pacemaker activity basically, because there's an action potential coming from here. So it's depolarize, 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 depolarize. And when the action potential is here approximately, these cells are already repolarized and ready to depolarize. But there's not yet an action potential coming from above. So that means they depolarize, depolarize. And these cells, like I said, are ready to depolarize again. So we have the closed conduction loop. What is important, of course, we have a sufficiently slow conduction of action potentials around the loop. That means only when we have an ischemia at one point, that doesn't mean there's every time a re-entry, but only at some point when the odds are right or for the patient wrong. Then we have this closed conduction loop, and every time it passes by this place, there's an action potential going down. And as I said, this is way faster than the SA node or whatever node is above this. So there are very fast and many action potentials generated at this time. The examples of some re-entry tachycardias and how they look like. For example, let's start with atrial fibrillation. In atrial fibrillation, the mechanism is the re-entry from many places inside of the atrium. So that means there are many conduction loops at different places, and only some of these action potentials are going through, and then there's the QRS. But there are a lot of contractions in the atrium. And if this re-entry happens not in the atrium, but in the ventricle, at one spot, then we see the ventricular tachycardia, because we don't see any P waves, but the ventricle is contracting multiple times, but regularly, because there's one re-entry happening, which triggers the contraction of both ventricles very fast after each other. And in ventricular fibrillation, we have basically the same mechanism, but we have many places of re-entry tachycardias at many points. So we have many closed conduction loops at many points of the ventricles. So the amplitudes are not the same as in the ventricular tachycardia, but they are different, and the heart at that point pumps very, very insufficiently. And this is one of the most dangerous rhythms that you can encounter. Because at that point the ventricles are so insufficient that no blood is basically pumping. Then again, here's an example of the ventricular tachycardia. This is monomorphic as here as well, because at one point there's a re-entry and the heart is still pumping but very fast, and you don't see any P waves. You just see the ventricle contracting very fast. Then atrial flutter. The difference between atrial fibrillation and atrial flutter is in atrial flutter we have again one focus of re-entry and not multiple like in atrial fibrillation. So that means we have a kind of regular atrial contraction, but it's still too fast to be conducted through the AV node every time. So we have basically a regularly P waves and some regular QRS complexes following. And here again, this is also an re-entry tachycardia, which you can see. What this is from the AV node and not from the ventricle, because we don't see any P waves, but only the AV node is starting and sending signals or depolarizations from the closed conduction loop around the AV node. Another arrhythmia that you have to know, and you will see it mostly in young patients, more pronounced, which is called respiratory arrhythmia or sinus arrhythmia. This is due to the difference in intrathoracic pressure, which is here explained. During inspiration, there's an increase in thoracic pressure. This leads to an increased venous return. This is then again an increased atrial filling. This leads to decreased activity of baroreceptors. This leads to the decreased vagal tone. And due to that, there's the decreased parasympathicus activity. And this increases the heart rate. And when you have the expiration, the mechanism is the exact opposite. But as you can see, there's a P wave in front of every complex. There's a QRS complex. The PQ time is below 200 milliseconds. The QRS is below 100 milliseconds. And the rhythm is regular, except here there's the inspiration and then there's the expiration at this part. Now we are at the end of the lecture. I have a quiz where you can check your knowledge a little bit. So now from every slide you can pause the video and think about the rhythm and how you would analyze it. And then I will explain afterwards how you should analyze it. We can see, again, from the very beginning, there are QRS complexes. So, and these QRS complexes are regular. We can count these little squares if they're regular, but they are. And now, in front of every QRS, there has to be a P wave, which in this case is true. There's a P wave, here's a P wave, here. Then in lead 3, here's a P wave. In lead AVL is a P wave, AVR is a P wave, E1. If you don't see a P wave in every lead, it's not a problem, because again, it depends on how you put the ECG on the chest. Sometimes you see it, sometimes you don't, but the important thing is that in some of these leads you have to see the P wave. If you don't see the P wave in any lead, then you have to go from there. But in this case, we see a P wave in some of these leads. The PQ time here is below 200 milliseconds, so we know it's the normal conduction. And the QRS complexes are small, so there's also no problem. So what is this? We know that is the P wave, there's a QRS, and it's a very fast rhythm. So this is the basic tachycardia, which is above 100 beats per minute. This can be caused by stress, by anxiety, by catecholamines, by multiple stress factors. So the next case. I will give you some time to pause the video and then we can see. Here we see again the QRS waves, so we see that there's activity. But it looks a little bit weird, because there's not a regular rhythm. These are regular, and then there's a break. So we know that there's something wrong. Now we can look at the P waves. Is there a P wave in front of every complex? There's a P, QRS, P, QRS, P, QRS, P, QRS, P, fused with a T again, and no QRS. Again, the QRS is narrow. I should have mentioned earlier. But what we can see is that the P wave is getting longer, or the PQ interval is getting longer, longer and longer, and then there's no QRS. So it's AV block second degree Wenkebach, because we see a prolongation of the PQ interval until one QRS is missing. But since the the SA node is firing regularly, we have again the start, we have again a short PQ time, which is getting longer and longer and longer until one QRS is missing, and it starts from the beginning. So now this is a very important ECG, because this is probably one of the most common arrhythmias that you will encounter. Here we have to see, is there activity? Yes, of course, we see QRS complexes. And then we have to look at the RR interval. So, for example, here it's almost two big squares. Then here's two squares and then maybe one small square more. Here is a little bit less than two squares, three big squares, two again, and so on. So we know it's irregular. Then what we have to do, we have to look at, or we try to find P waves. Are there P waves? Maybe in this lead? No. Here also not. If you are wondering what these are the T waves, because they are in a regular distance from the QRS complex. Here as well, here as well, here as well. You have to measure it by hand, or maybe you can count the little squares if you're not sure. But there are no P waves in front of the QRS complexes. So we don't see P waves. The QRS, the RR interval is irregular. And we don't see, like for example, in the AV block second degree, Mobitz or Wenkebach, doesn't matter. We don't see any regular, I would call them regular irregularities. Here it's just irregular. I'm not sure if you can say regular irregularities in the clinic. I wouldn't advise you to do it, but for now you can think of it as such. So here it's just irregular. We don't see P waves. The QRS complexes are still narrow. So this is atrial fibrillation. And this is an ECG that where I took a picture a while ago from the clinic. So you see what else can be wrong. It's not important that you know it, it's just nice to know because you see it very often in the clinic. Again, here's activity. There's a P wave in front of every complex. Here's a P wave, P wave. But the PQ interval is also below 200 milliseconds, so it's fine. But the QRS complex in this case is longer than 100 milliseconds. I will explain in the pathophysio lecture what does this mean. This is not important for you yet. But what is important to know, because you will see it a lot in the clinic, are these small lines in front of every QRS complex and after the P wave. Do you know what it is? I can tell you. These lines are from the implanted pacemaker in the ventricle of the patient. So it means that after every P wave, the action potential gets conducted and the pacemaker recognizes it and sends this stimulus to the ventricle so the ventricle can contract. So just keep in mind, if you see these small upstrokes after the P wave, it's a ventricular pacemaker. If you see it before, or you don't see any P waves, when you see these, it's ventricular or atrial. Okay, thank you very much for listening. I hope it helped you a little bit. And if you have any questions, you can contact me. You find my name in the IS. And thank you very much.